Welcome to the LDN radio show, brought to you by the LDN Research Trust. I'm your host, Linda Elseygood. I have an exciting lineup of guest speakers who are LDN experts in their field. We will be discussing low-dose naltrexone and its many uses in autoimmune diseases, cancers, etc. You're invited to join us on air, asking your questions by calling in on the local rate phone numbers in the UK and the US, which can be found on ldnradio.org. Thank you for joining us. Today we're joined by psychiatrist Dr. Mark Shukhman, who practices in the suburbs of Chicago. Belmar Pharmacy is a nationally respected compounding pharmacy. They compound low-dose naltrexone, LDN, bioidentical hormones, and custom amino acids and mineral blends. They are based in Colorado and ship nationwide. Their goal is better patient outcomes through quality compounding, combining effective communication between practitioner, pharmacist, and patient. Call 1-800-525-9473 or visit belmarpharmacy.com. Well, thank you for joining us, Mark. We've got a very exciting program here today.
Thank you very much for inviting me. I would be very happy to participate in this program. I was listening to to what you said before, and I'm so happy we'll not be talking today about cancer. We'll be not talking today about many bad things, but we can talk about psychiatry. Mm-hmm. Well, even if somebody has a cancer or somebody has a chronic physical illness, they frequently end up in my office. For some reason, people believe that if somebody has a big illness, it's okay, it's normal, it's expected to be depressed, to be anxious, to lose hope, not to have energy, not to sleep. And it's frequently not the case. Frequently, a mental condition is joining the big illness. And the sad part is that it's frequently treated. Frequently, people can feel better, but for some reason, they don't want to do it. They think it's okay. And partially, my interest in coming forward and talking about low-dose naltrexone and psychiatry was because I was trying to address these people with chronic medical illness and tell them that, yes, LDN can do not only miracles for your condition, but also for your mood, anxiety, sleep, sex, appetite, energy level, memory, and not having mental fog, and some other things. So I probably said enough.
No, carry on.
I'll be happy to join your conversation.
Mm-hmm. So if somebody comes into your office with, let's say, Crohn's disease, and they're feeling very down and depressed, they're going to the toilet too often, they're probably bleeding, losing weight, all of those things obviously would cause a person to be anxious and depressed. And when you're not able to do what you used to do and have that taken away from you is upsetting, whatever condition you've got. What would you say to that person in your office on the first visit?
Well, it's normally very difficult to convince a person who goes through all these troubles that no, it's not normal to have this bad mood. It's not normal to feel what you feel. Yeah, partially it's normal. They lose mobility, they lose friends, they lose life. And yeah, as a reaction, as an initial reaction, it's a normal thing. But after a while, most of the people are adjusting to the situation. One of the favorite saying is, even in jail, not everybody is depressed. So if brain works as it's supposed to work, it will eventually adjust to the condition. And yes, you cannot do these things with your illness, but there are a lot of other things you can do. Yes, you cannot enjoy what you used to enjoy, but let's find out what you can enjoy. So if you're asking me what I'm doing in the first appointment, I almost never say you have depression. But I always can say we can improve your sleep, we can improve your energy, we can improve your appetite. So I am trying to give the person something tangible to start with. And then later we talk about depression, because there is a big difference between normal appropriate reaction to what's going on and having this additional illness. You mentioned Crohn's as an example. Actually, Crohn's is very commonly associated with depression, even between flares. And the best evidence that these people often have two illnesses is that they get better when depression is treated. Antidepressant is not a magic, it's not a drug for good mood. It's not a drug that people can take and feel good for no reason. They just don't get stuck with thinking about illness all the time. They're not preoccupied with illness all the time. They are more flexible in their thinking. They come up with some solutions that they didn't come up without a medication. So probably everybody who is not doing well and has a big illness should think, is depression is something that I have on top of my illness? Because depression is treatable. At least it's easier, much easier treatable than the big illness that many of the patients have.
I'm sure that people listening at home would find that very reassuring, Mark, because when you feel that way, it feels as though there's no end to it, isn't there? And do you prescribe LDN as a first-line treatment, or do you try other things first?
You know, the type of the practice that I have, I rarely have patients who are totally naive to psychiatric medications. Normally, people end up in my office after they tried 1, 2, 3, 4 primary care and psychiatrists. Mm-hmm. And when nothing works, they are announced to be treatment-resistant depression or depression not otherwise specified, or whatever depression, they end up in my office, not really hoping to get something better from psychiatrist number 5, and they get from psychiatrist number 4. Of course, I don't have a luxury of taking these people off of their medications and say, okay, forget everything you were doing before. Here is low-dose Naltrexone. It will solve all your problems. So no, I am adding Naltrexone to the medications the people are already taking in the beginning. Mm-hmm. And then when they are bad, we can decrease medications or stop medications that they are on right now. Sometimes I use supplements, vitamins, whatever, to ease the process. And sometimes people just decide to stay on a combination of psychiatric medications and LDN. Are they getting better because their autoimmune condition is treated? Are they better because LDN is helping psychiatric condition? Well, I'm not doing double-blind placebo-controlled studies. But if you would ask me, probably the processes are independent. LDN is doing a lot of things. In the beginning, it was thought that LDN increases endorphins. And to be honest, it's debatable whether it increases endorphins or not. Whether this increase in endorphins for a few hours really makes the difference or not, I don't know. But LDN is doing a lot of other things. LDN is decreasing inflammation. It's working on immune system. And we know very well by now connection between inflammation and depression, inflammation and anxiety, inflammation and other things. LDN specifically works in these toll-like receptors, number 4 in glia. It's cells in the brain that support brain cells. And this mental fog, brain fog, is one of the evidence of this inflammation. So is depression getting better because this inflammation goes away? I don't know. It's very possible. LDN actually has a direct effect on dopamine receptors, and depression caused by dopamine receptor dysfunction is very well described. I can spot these patients among my depressed patients. So these are probably very important mechanisms by which LDN is helping depression. So not only people get better because their illness is better, but also because it is treating depression specifically.
Mm-hmm. We do have a question from a lady called Hazel. She says, how can I give myself a lift? I don't suffer from depression per se, but do get irritable easily. I follow an SCD diet and take 3 milligrams of LDN for Crohn's. What can I do to help psychologically? Maybe increase or decrease the LDN. What is your advice?
Let me make sure that I understood the question already. So this lady is taking LDN already for Crohn's.
Yes.
Yes, and she doesn't feel very depressed, but she feels irritable.
Yes. Yeah? She says she gets irritable easily.
Mm-hmm. And what is her question?
What can I do to help herself psychologically? Should she increase the LDN or decrease the LDN? What she's asking is the 3 milligrams right for her since she gets irritable easily?
Okay. So there's no simple answer to this question. And what I would do in your case, I would try to take a little bit more LDN. I will try to take a little bit less LDN and see what is happening. I would like you can divide LDN in 2 doses. You can play with the time you take LDN. I'll tell you why I cannot answer this question directly. You are talking about increased irritability. There's so many reasons for increased irritability. It can be sleep deprivation. And LDN, if you take it before bed, it can, well, I wouldn't say disturb your sleep, but change sleep architecture. And for some patients, it becomes curative because one of the treatments for depression is sleep deprivation. People can get manic when they're sleep deprived. So you might be irritable because your sleep architecture changed. In this case, move naltrexone from nighttime to morning time, at least to try. It's possible that LDN is activating you too much. Then try to split the dose. It's possible that this irritability is a part of depression. Now, when a psychiatrist says depression, it often the psychiatrist means something else that people in real life. Sometimes you can say my favorite football team lost and I was so depressed for a few hours. Well, we say you were not depressed, you were upset, you were unhappy. It's not depression. Depression is something else. Depression is a bunch of symptoms that include not only mood, which should be officially by definition said more days than not for about 2 weeks. You have problems with anxiety, preoccupation with negative. Sleep can change. You can sleep more or less. Appetite can change. Energy level can change. This is what we call depression in psychiatry. So you don't have to be actually sad to be officially diagnosed with depression. And maybe irritability is part of this depression. Maybe irritability is part of activation from some other medications you are taking. Maybe you are bipolar. So unfortunately, it's very difficult to give specific advice in this case. But one of the advice that is never wrong, play with naltrexone. Naltrexone is a very safe medication, and nothing will happen to you if you try a little bit more, a little bit less. If you go above 5-6 milligrams, probably this is no longer a low dose naltrexone. But low dose actually is a very relative term, and you can find a lot of literature talking about 0.1 milligram of naltrexone, 0.01 milligram of naltrexone, and less. Mm-hmm. Some doses can help autoimmune conditions better. Some doses can work better for pain. Some doses can work better for depression. So play and try to see what works for you. And by the way, maybe you need to be evaluated. Maybe something else is going on. Obsessive people are very often irritable.
Thank you for that, Mark. And we have another question here from a lady called Donna. She says her nephew is a family practice MD and he feels that fibromyalgia will be found to be a mood disorder. And do you have any thoughts on that?
Fibromyalgia is a very interesting disorder that no specialty wants to owe this disorder. Neurologists don't want to deal with it. Rheumatologists don't want to deal with it. Psychiatrists don't want to deal with it. Patients are suffering. I think it is real. But I think that you cannot put a label. First of all, you cannot put a label on all fibromyalgia. There is no good definition what fibromyalgia is, and a lot of different conditions they end up being labeled as fibromyalgia. So what is clearly present in fibromyalgia? In my view, there is no fibromyalgia without a sleep disturbance. And if you have a sleep disturbance, you cannot not to have a psychiatric manifestation of any kind. So will it be a mood disorder? I do not know. People with fibromyalgia normally feel kind of not only hopeless and helpless, which you can attribute just to the situations that they have an illness and nobody can find out what's wrong with them. Not only because of chronic pain, but my guess they normally are flat. And again, is it secondary to sleep deprivation or not? Do we use antidepressant medications to treat fibromyalgia? Yes, one of the very effective medications for fibromyalgia is duloxetine Cymbalta, which is an antidepressant medication. Is it because this medication has noradrenergic activity and it helps pain, or because it directly addresses mood problem? I do not know, but it works. Patients with fibromyalgia who ended in my office, very rarely they don't take an antidepressant. So somebody before me was thinking that the person is depressed. Is this a reaction? Or what I can tell you that just treating depression will not treat fibromyalgia if it's real fibromyalgia. Mm-hmm. So probably this is not one of the mood disorders. But yes, mood disorder is a part of fibromyalgia that has to be treated.
Lovely. Thank you. We'll just have a quick break. If anybody would like to call in with their questions and speak to Dr. Mark Shukhman live on air, you can find the local call-in numbers for the US and the UK on www.ldnradio.org. We'll be back in just a minute. The LDN Research Trust has its own forum, which can be found at forum.ldnresearchtrust.org or via our website. The forum is divided into sections, so it's easy to navigate and find what you're looking for. You can share your experience, ask questions, keep a journal, etc. Unlike Facebook, the posts are always easy to find and don't get buried. We have a private medical professionals only section. To find out more, please email me, linda@ldnrt.org. Belmar Pharmacy is a nationally respected compounding pharmacy. They compound low-dose naltrexone, LDN, bioidentical hormones, and custom amino acids and mineral blends. They are based in Colorado and ship nationwide. Their goal is better patient outcomes through quality compounding, combining effective communication between practitioner, pharmacist and patient. Call 1-800-525-9473 or visit belmarpharmacy.com. Welcome back, Mark. We have another question here for you from another Linda. And she says, How do you know if what she says I call normal depression, say after following surgery and pain limitations, and depression that needs treatment?
It's a difficult question. And if this is the first depression in your life, if you did not have depression in your family, history is not significant for depressions in the family. Depression, anxiety is a variant, obsessiveness is a variant. So if this is the first time you're depressed in your life, okay, relax and wait. You can wait and you can see what's happening. But if your pain goes away, if it's already, a month or more after the surgery, and you still are pessimistic, guilty for no reason, worrying, cannot sleep, don't have energy, are preoccupied with your illness or with anything else, then maybe you have a depression. But there are some bigger criteria for depression. But the biggest question is, if after a reasonable time you're not feeling better, should you wait longer? Yeah.
Her question goes on. She says, I was so much better on LDN and gabapentin for fibromyalgia until I had major back surgery. Since then, I've been taking pain pills for 4 months and my husband has noticed I am depressed. But I wonder if it isn't normal to be depressed after such a surgery, and she's got in brackets, combined with family issues. And at what point does it become a problem that needs treating?
Let me stop and comment a little bit about, I had a big problem, surgery, my medical problems combined with family problems. So it's always the biggest problem. Is it a new stress, or you just realized that you cannot tolerate this stress anymore? You lived with somebody who didn't have big problems before, or you were able to tolerate these problems before you had worsening, because your ability to tolerate this stress or take this crap anymore is exhausted. So when, and people normally, this is how our brain works. We become depressed, but the brain needs some explanation. We're rational people. We want to know, why am I feeling differently? What is happening to me? And people always can find some reason why they feel depressed or unhappy. Lately, a lot of my patients are still telling me they are still depressed or drinking more or don't want to get pregnant because Trump won. A little bit before that, even a few years ago, an old lady she couldn't explain why she's depressed. Nothing was going on in her life. She lives alone, she has normal income, and she became depressed. And I asked her why. And she said, oh, because 9/11, because what happened? It was many, many years after 9/11. But our brain is trying to explain to us why we're depressed or anxious or worrying or preoccupied. And in your case, if something is going on in the family, well, this is why I am depressed. But there is another aspect. You moved from low-dose naltrexone, which is an opioid blocker. Yeah, it doesn't block opioid receptors for a long time, but it blocks opioid receptors. It makes opioid receptors more sensitive. And you are now on opioids. So, first of all, you're no longer on LDN. You're on opioids. So you switched your drug to the opposite, from blocking receptors to satisfying receptors. For some people, opioids are antidepressants. And this is clearly true. For some people, they feel dysphoric. Your receptors are now sensitive. And when you switch to opioid medications, it's very possible that your receptors are reacting this way. When you are on opioids and they don't give you enough of opioids and your receptors are sensitive, you go from into small withdrawals, which cannot come with good mood together. You might not sleep well, which might not help your mood. Narcotics are pro-inflammatory. If you had an inflammatory condition to begin with, and you are now on a narcotic, your inflammation might flare. So inflammation in the glial cells of the brain gives you depression. There is something called sickness behavior of, the pet owners know that when your pet is sick, you can see its behavior changes, probably mood changes. How does a dog or cat know that they should change behavior? Well, this inflammation or this disease process in the body changes how brain works. So maybe following this surgery, when you are on pro-inflammatory medications, you got depressed. So in your case, treat your depression. If you are in doubt, treat your depression. After so many pills that you took for your illness, after so many things that happened to your body during this surgery, then why are you afraid of an antidepressant medication? It's a big question when to start treating depression. If you think your reaction is appropriate, you can wait. How long to wait? I do not know what are the expected lengths of feeling bad. It depends on your stress at home that doesn't go away. It depends on your pain that doesn't go away. Will you tell yourself, I will wait half a year? What if after half a year you're not better? You will start treating yourself half a year later. Why? If essentially taking these medications doesn't cause big problems, to be honest. And of course, I cannot say legally, I cannot say they're harmless. But in practical life, probably harmless. So instead of asking question, what is normal for the situation and what is not normal for the situation, the appropriate question is, what do I want to do with it? Can I still tolerate what's going on? Or I better take a medication, feel better, and then if I don't need it anymore, I'll drop it. Mm-hmm. Probably this is more appropriate approach to the situation.
Okay, thank you. We'll go on to the next question. And they didn't want to leave a name. And it says, I'm learning about LDN for circloderma and depression, and they take sertraline. And can that be taken in conjunction with LDN? It says, I'll be interested in Dr. Shukhman's views on using LDN for addiction. And would that include sugar and junk food. So there's two questions there, really.
Okay, so there are two questions, yeah. One question, my understanding that first question is, can I take LDN with sertraline?
That's right.
And apparently the person who is asking the question read somewhere that is contraindicated or...
no, they just want to know if it's okay to take the two together. They didn't know.
Yeah. Let me answer this question. And second question is about addiction and LDN. Okay, so, why sertraline works on serotonin and LDN works on opioid receptors? Well, maybe it has something to do with dopamine, but clearly doesn't have anything to do with serotonin. So on one hand, yeah, this is totally different medications, and you can take them together. And well, I shouldn't say I shouldn't say nothing can happen, but let me tell you this way: a lot of my patients on Zoloft are taking LDN and feel good and feel actually better. And by the way, Zoloft was one of the medications used in the recent study by Harvard about preventing of relapses from depression by using LDN. So why this buzz about specifically Zoloft? Why Zoloft was chosen as a medication for this study? Zoloft came to the market as an antidepressant that is working on serotonin. Apparently, if you go high enough on the dose of Zoloft, it becomes a little bit dopaminergic. Probably you need to cross 150 milligrams, maybe close to 200 milligrams. It becomes a little bit dopaminergic. But there is a big difference between dopamine and opioids that are affected by LDN. Yes, if you work on opioid receptors, dopamine will also increase. But I think this increase is so negligible that these two medications together, in my view, are perfectly safe to take together. If worse come to worse, you will feel that you don't like it, you don't tolerate it, you have side effects, and you will stop one of these medications. So first question, take it, don't worry, from my standpoint. Second question is about treating of addiction with low-dose Naltrexone. And I am very glad that alcohol was not mentioned as one of the addictions that you're trying to treat with low-dose Naltrexone, because I tried to treat alcohol addiction with low-dose Naltrexone for a long time, and eventually I agreed with Claudia Christian that said that no, for so-called Sinclair method, 50 milligrams is probably more appropriate dose than a low-dose Naltrexone. But with some other addictions, I do get success with low doses. This is the idea. Every time you're engaged in behavior that is a part of addiction, dopamine is released in your brain. Dopamine is released, and from the release of dopamine, you say, oh, it's good. This is what I want. At the same time, when dopamine goes up, at the same time, endorphins increase. And endorphins work in another part of the brain. And this other part of the brain is kind of getting, gets memory. Okay, I did this, and it was good, and I want to do it again. So what is happening if you take low-dose Naltrexone before the behavior? You still get increase in dopamine because low-dose Naltrexone doesn't affect dopamine. So you still engage in this behavior, and it feels good. But the next mechanism, which tells the brain, okay, let's remember it because I did it and I felt good, is blocked because the second mechanism is determined by endorphins. So if before each behavior that feels good and is a part of your addiction, you take low-dose Naltrexone, allegedly you still enjoy this time, but you're less likely to be engaged in this behavior next time. The best example I found, and probably this is not the best, but probably it explains mechanism very well. You see a bear dancing in a circus. Why this bear is dancing? Because you give him a treat. So what's going to happen if you stop giving this bear a treat? Well, it will dance one time, it will dance second time, it will dance third time, but then why should I dance if I don't get any treats? So this is the mechanism behind low-dose naltrexone working for addiction. What's going to happen if you didn't give the treat one time, second time, third time, and then gave the treat to the bear? Well, the bear will continue dancing. So the most difficult part of this treatment is to take naltrexone every time, and to take naltrexone in the right dose, right timing, before the addiction, before the process of addiction. Otherwise, you can enhance addiction, not extinguish this behavior. But in right hands, with right application, right art, can help actually, and is very effective for addiction. I used it for gambling addiction. I use it for internet. I used it for sex. Sometimes for organized people, it works for addiction for food. Actually, naltrexone is a part of a lot of medications for appetite control. But my guess it's not as good as taking naltrexone just before the behavior that you want to extinguish. So before you start binge eating, it would be nice to load yourself with naltrexone, which sometimes is possible, sometimes not.
Mm-hmm. And if you,
does it answer?
If you just very quickly, my mind is ticking here. Mm-hmm. If you were a junk food person who just craved junk food throughout the day, every time you had a craving to eat, I don't know, chocolate bars or chips or that kind of thing, how many times a day could you take the naltrexone then to break that pattern?
In my view, as many times as you need, but it will probably not work the way it intends to work if you take it more often than once every 3 to 4 hours. But every 3 to 4 hours, you can probably take it. My guess that, and again, it depends on the dose, that naltrexone will not block receptors for more than 3 or 4 hours if you take the right dose. Unfortunately, it's tricky because you need to take it a little bit ahead of time, and the right dose ahead of time. So what do? You just wait and you tell yourself, I will eat this donut in 2:15, and I don't need to, and I cannot touch it now. Well, if you have this willpower, don't touch it. Now, what's going to happen if you take naltrexone and you don't take a donut? Or what happens? And by the way, to make it work, you need to eat this donut. If you're avoiding eating donuts, the system will not work. This is one of the obstacles why this method didn't become a mainstream method for alcoholics, because in this case, the doctor should tell the patient, take naltrexone and go ahead and drink.
Yes.
So officially, the doctor cannot say, at least in the United States, the doctor cannot say, go ahead and drink.
Okay.
But otherwise, this method doesn't work. Okay.
Well, we're just going to have another quick break, and then we'll come...
Yes, theoretically, this is right. Quick. Uh-huh. Mm-hmm.
Do you want to finish what you were saying?
No.
Okay.
No.
We'll be back in just a quick break with lots more questions. Thank you. The LDN Research Trust is very proud of the LDN book, which was launched at the LDN 2016 conference in Orlando and has been a great success, not only for the medical profession, but for the patients wanting to learn more about low-dose naltrexone. Full details can be found on the homepage of the LDN Research Trust. Discounts are available on bulk orders of the book, which is 10 or more. For details, email me, linda@ldnrt.org, telling me how many copies you wish and where you live. I will then be able to get Chelsea Green Publishing to contact you. Belmar Pharmacy is a nationally respected compounding pharmacy. They compound low-dose naltrexone, LDN, bioidentical hormones, and custom amino acids and mineral blends. They are based in Colorado and ship nationwide. Their goal is better patient outcomes through quality compounding, combining effective communication between practitioner, pharmacist, and patient. Call 1-800-525-9473 or visit belmarpharmacy.com. Welcome back, Mark. We have a question from Jill Brooke, who's one of our research advisors, and she's saying, I wonder what lifestyle habits Dr. Mark Shukhman recommends for maintaining good mental health, especially if bad mental health runs in the family, such as bipolar disorder and schizophrenia. Can a healthy lifestyle prevent mental illness?
Oh, it's $1,000 question or more. Unfortunately, I have to say that I'm not very positive that there is a certain lifestyle that can prevent you from having a problem or relapse, especially if you have a family history. If you have a family history, you have probably genetic predisposition for that. What I can say, what can help, so clearly having good sleep hygiene, having good sleep can help. Tons of research is linking sleep deprivation, poor sleep, with a manic episode, with a bipolar illness, having sleep apnea probably doubles, triples, quadruples your risk of having an episode. And many people don't know that they have sleep apnea. Many people think that if they fall asleep right away, then it means, and don't wake up at night, that it means that they have wonderful sleep. The question that I ask, how do you wake up? Do you feel refreshed in the morning? So if you don't feel refreshed in the morning, you need to do something to your sleep. Otherwise, your risk of having a mood episode is increasing. Sleep apnea is increasing likelihood of anxiety episode, of attention deficit, and so on. Food-wise, most of the websites are telling you not to eat fat and proteins and stay. Well, healthy food, in my view, healthy food doesn't mean salads only. In my view, healthy food doesn't mean fiber only. Actually, if you would, if you remember Disney movies, how do they depict a good fairy? A good fairy is plum. I never saw a good fairy who is thin. So probably having low cholesterol doesn't help not to have mental illness. Having too high of cholesterol is another problem. You can develop dementia eventually, but too low, I wouldn't say it's the right thing. So now we're talking about before we talk about vitamins and supplements, hormones. I started helping people by adjusting their hormones a few years ago, and I have wonderful results. I see that sometimes adjusting patient's hormones helps much better than antidepressant medication, much better than anti-anxiety medication, much better than sleeping pill, People feel younger, people feel better, people are less likely to develop a mood episode, actually a connection between estrogen, progesterone, whatever, and bipolar illness is very clear. Having postpartum depression, which is just an evidence of hormonal disturbance, is one of the biggest risk factors for being diagnosed with the bipolar disorder later on. Or if you have a bipolar disorder, you're very likely to have postpartum depression. So adjustment in hormones are very important. Looking at thyroid is very important. The way thyroid is treated in official standard medicine is just unacceptable. They're confusing two fundamental things. They're confusing normal level with optimal level. They're confusing these levels were established 150 years ago just by measuring blood level in a lot of people, and nobody asked them how you feel. The only exclusion was, do they have Graves' disease or not? Do they have thyroid or not? So this can help you not to have an episode of mental illness. Inflammation is cannot underemphasize what inflammation can do to make your genes express themselves. So I can probably go on and on. If you have family history of dementia, or you have a lot of inflammation, vascular problems, and you might be a candidate to have dementia later, there's a lot of things you can do in terms of lifestyle to, well, I shouldn't say prevent, but I can say delay dementia. Food-wise, again, I said I'm not a big fan of, in my view, healthy eating does not mean salads only, lean, no fat. I think this doesn't help mood. All this area of having allergies to food ending up in a psychiatric manifestation. All these microbes that live in your gut. By the way, everybody should be checked for this gene that is responsible for methylation. I have patients whose mood problems just stop, and they don't have any more flare-ups after I put them on folinic acid or methylfolate or deplete, one of the derivatives of folic acid. I read that sometimes schizophrenia goes away. I didn't have anybody with schizophrenia who improved this way, but clearly bipolar and depression and migraines go away with it. So it's a question. You can touch any aspect of your life, and this any aspect could be basis for a big lecture.
Mm-hmm. Okay.
Do my patients adhere to my recommendations? Well, some do, some don't. If they don't, I no longer get upset. I understand it's part of their depression or lack of motivation or feeling overwhelmed. But ideally, yeah, I would be happy if everybody adheres to some life modifications.
Okay.
Make some life modifications.
The next question is from Leora, and she says her brother began experiencing severe life-altering panic attacks when he was in college. They came out of nowhere with no noticeable triggers. After much testing, there was no cause found. The only thing that helped him was benzodiazepines, which he's taken for nearly 10 years. He knows they're addictive and has consequences, but coming off them are dangerous as well. Could LDN help? Do you have any other insights or suggestions for coming off benzodiazepines?
I'm doing a lot of addictions. And addiction to benzodiazepines or dependence on benzodiazepines, it's not necessary that you still enjoy them. or they still help you, but you cannot stop them. It is a very interesting area, and to be honest, almost nobody knows what to do. There is a famous Ashton protocol when they suggest that you switch your benzodiazepine to Valium, which somehow was chosen as a standard, and then you decrease it slowly. It sometimes works, sometimes doesn't work. But what is lacking? You said that panic attacks started for no reason in college.
Mm-hmm.
I'm an example of a psychiatrist who doesn't believe in spontaneous panic attacks for no reason. It's like you're telling me I have a cough and I don't know why I have a cough, but please treat my cough. I would be interested, is this because you have a flu, or you have cancer, or you have pneumonia, or you have postnasal drip, or whatever. And I would rather treat the reason for this rather than just giving you medication to suppress your cough. So yes, benzodiazepines are wonderful to suppress panic attacks, but getting hooked on them is awful. So did I ever try to use LDN for benzodiazepine withdrawal? To be honest, no, because people who are on benzodiazepines they're not easily willing to take something unknown, something to touch another receptor. Maybe I should look into it. What I know for sure that this question was very typical. I know I need to stop my benzodiazepines, but this is very dangerous. Well, believe me, this statement is clearly overrated. If you dropped a big dose of benzodiazepines, yes, you're more prone to have seizures. If you don't have seizures, you might have, ringing in your ear, you might have insomnia. But, the statement that it's dangerous is clearly overrated. It might be dangerous. Most of the time it doesn't, and especially if you're on a small dose. What LDN can help you with, probably if you take LDN before your benzodiazepine, probably half an hour before, it might decrease this link in your brain that when I take benzodiazepine, I feel better, and I'm not afraid, and everything will be fine. And so try this. Try take it before your benzodiazepines. Can you mix them? I don't see any reason why you cannot mix them. But it's probably not the main medication for benzodiazepine withdrawal.
Okay,
yeah.
I think we will have time for one more question. I have a question from George, and he says he takes LDN for fibromyalgia, and he was hoping it would help with depression. He started on 0.5 and has recently moved up to 3.5. He says, my depression is very resistant, and there's a lot on my plate with bipolar, depression, etc. I've read that some people can get depressed while on LDN. How can I be sure it isn't the LDN that is making me more depressed?
So, again, one part of this question is how much to take, and second question is when I increase my LDN, will I get more depressed or not? So the first question, please ask experts on fibromyalgia. In my view, you can play with LDN. You can change the dose. You can go up. You can go down and try what works for you. But second question is very interesting and very, very frequently asked. Does LDN cause depression? So when I was preparing for my first presentation, I had a number of slides because I want to be very organized, and before talking about benefits of LDN in psychiatry, I wanted to make a statement that no, LDN is not expected to worsen your depression. So how this idea of worsening depression came about? Well, dopamine, LDN is blocking opioid receptors, and that's why you can get more depressed. This is a common thinking. You don't enjoy as much because your endorphins are not hitting on opioid receptors. Well, in fact, I will be honest with you, a lot of patients who stay on high doses of naltrexone might report depression. But my guess that not all depression is equal. We need to find out why they take high dose of antidepressant of naltrexone. For example, somebody who used to drink and suddenly started taking high doses of naltrexone and stopped drinking. Well, are you more depressed because you stopped drinking? Are you more depressed because your body still did not change from getting easy fuel from alcohol to now getting energy from food? So it's a lot of variables. But there were a couple of studies that looked specifically into naltrexone, high dose. One study was naltrexone that was tried for schizophrenia. Another study was naltrexone that was tried for treatment of alcohol dependence. And as a secondary measure, they did do depression scale, and they found no increase in depression. So most of the studies didn't find any increase in depression, even on high dose of naltrexone. Low dose of naltrexone actually is going to increase your endorphins. It's going to make your receptors more sensitive to pleasure. So I don't expect that low dose of naltrexone can cause depression either. Mm-hmm. Do I see it in my practice? No, in my practice I treat depression with low dose naltrexone. Will any depression respond? No. That's why it's more art than science to find the right patient, the right dose, the right regimen. But it does help depression. So if you feel more depressed on antidepressant, I wonder, did you take, and especially for fibromyalgia, did you take opioid medications before and now you're taking low-dose naltrexone? Yeah, blame times that you were on opioid medications. Do you have less pain? Okay, pain also increases endorphins. And now you have less pain, you have less endorphins, and your brain reacts to this with depression. There's a lot of variables. But before blaming LDN for causing depression, you need to eliminate, you need to see what else is going on. And in some cases, you have nothing to do. You need to stop it.
Wonderful. Well, we've run out of time, Mark. We'll have to get you back another week. And thank you very much for sharing all your experience with us. It's been totally amazing. I'm sure it's been a big help to those people with depression. And as I say, we'll have you back on another show. And we have another show live on Friday with Jill Brooke talking about New Year's resolutions and how to look forward to eating and behaving healthily in 2017. So thank you very much, Mark.
Thank you very much for inviting me. Mm-hmm. Thank you. Goodbye.
Belmar Pharmacy is a nationally respected compounding pharmacy. They compound low-dose naltrexone, LDN, bioidentical hormones, and custom amino acids and mineral blends. They are based in Colorado and ship nationwide. Their goal is better patient outcomes through quality compounding, combining effective communication between practitioner, pharmacist, and patient. Call 1-800-525-9473 or visit belmarpharmacy.com. Any questions or comments you may have, please email me, Linda, Linda, at ldnrt.org. I look forward to hearing from you. Thank you for joining us today. We really appreciated your company. Until next time, stay safe and keep well.